So, hi guys, I'm Krishanu here, and a little bit of background of mine. I have been working as a mechanical engineer for 11 years, more than 11 years now, and most of my work has been across in the medical industry. Although I have worked in other sectors also quite a bit, but a majority of my work has been in the medical devices sector. And in the amount of time I've spent in the medical devices sector, I've spent a majority of it working on ventilators, and that's why I'm here today, just to take every one of you through the basics of ventilator and understanding the nitty-gritties of it, and why it is a very difficult engineering challenge to have, right? So to begin with, let's start from the agenda here on. So so we are basically going to look at the types of ventilators that are there in the market. So this is going to be a very broad perspective of ventilators. We are not looking at ambulatory or transport ventilators here, just the kind of ventilators you would find in a regular hospital. And after that, we're going to look at the ventilators that would be needed in the current COVID situation, and what are the problems that you face, and then how you could be treated for that, right? And then we'll take a deeper dive into the working of the ICU ventilators, where I'm going to take you through how each module works and why is it needed and stuff like that. And then we will go through the different mechanical ventilation modes, in which you will have the kind of modes that a ventilator needs to run on, and the kind of sensors that are needed for it, and how an electronic control needs to be in to handle all these modes. And most importantly, last but not the least, the lung trauma that is caused by ventilators. So this is going to be a very basic overview of the kind of damage a ventilator can do to the lungs. And anybody who's even thinking of making a ventilator should have this as one of their most prior highest priority information, and they need to be very wary of how a ventilator can damage lungs. So going on from here, so the if you go back in history, ventilation started from something known as a Mapleson circuit. A lot of you guys find the ambu bag or the gamma bag everybody talks about right now. And this Mapleson circuit is nothing but just an elaborate balloon with a couple of NRVs, and you have a fresh gas inlet, if you can see here. So fresh gas is nothing but a combination of uh, oxygen, air, and little bit of anesthetic agents if needed. So this circuit is primarily used when the patient is fully in coma and cannot breathe at all, or say anesthesia induced coma is there, so he cannot at all breathe. So they pump fresh gas in to ensure that the coma state is always there, and the ammo bag is pressed by the respiratory therapist or whomsoever is doing it. And this is a state where a patient cannot breathe at all. So from here, the ventilators basically graduated to the anesthesia ventilators that you can see in the right side. So so most of these anesthesia ventilators are a better version of the Mapleson circuit, and they basically are used to ventilate patients who are under anesthesia. So as the word says, right, that the anesthesia ventilators will be used on patients who are completely on in coma or undergoing surgery, and they have no breath of their own at all, and they have all pressure monitoring, volume monitoring, and all the other uh, essential monitoring systems that an OT needs to have. And it ensures that the right percentage of anesthesia keeps going into the patient during surgery, and the anesthetist, whomsoever is there, can sit on the table that you can see there, and have a look at all the parameters and keep the patient alive during the surgery. So that's basically the job of this ventilator. It's to ensure that the patient is always in coma during the surgery, and also to ensure that the patient is alive by checking all the vitals and whether everything is fine or not. Right. And the most advanced version of it, the broad spectrum of the most advanced version of it is the rightmost here that you see. They're called ICU ventilators, and these ventilators are used on in your regular ICU, where you see either a patient can breathe completely, or they basically give assist to breathe to a lot of patients. So these ventilators basically even detect and understand how a patient is breathing, and try to mimic their breath, and try to ensure that a patient can be weaned out of a ventilator. So basically, a lot of patients would be in coma, and they would take time uh, to first they will take ventilator support, and slowly they have to be removed from the ventilator. So it's only this ICU ventilator that is capable of that kind of a functionality in ventilators. So uh, coming to the next topic, what kind of ventilator is needed for this current COVID situation, right? So a lot of patients whom you see are tested for COVID positive and need ventilation. Nowadays, COVID usually induces something called as ARDS, which is acute respiratory distress syndrome, and that can be mostly tackled with an ICU ventilator, and the Mapleson circuit and anesthesia ventilators can only be used in case of these patients being sedated under anesthesia, and you induce coma and then you give them that ventilator. But however, if you have to get them out, which is which is the most amount of time. So when you sedate a patient and give them anesthesia ventilator or the Mapleson circuit, after you take him out of sedation, you have to slowly bring him to full consciousness, and he should be able to breathe 100% on his own. So when this phasing out of the ventilator comes, you need to always ensure that the ICU ventilator is the one that can do it, because that will be the one that will be tracking and monitoring the breath and changing its mode as per what the patient needs. So I think I've pretty much covered the assisted ventilation here in my previous discussion over here, and weaning patients off the ventilators is just what I'm saying. So ICU ventilator is something that is needed to ensure that you can take patients off of a ventilator. After that, the next very important requirement for patients suffering from ARDS is a requirement of PEEP. So PEEP stands for positive end expiratory pressure. So this is the amount of pressure that is always kept inside the lung when you're doing when you're getting mechanical ventilation. This is very important for ARDS patients, so that the lung walls and the alveoli walls do not shut in on themselves, and if they do, it becomes very difficult to reopen them, because the lungs and the lung walls and the alveoli walls also will have some percentage of edema, some amount of edema, and that edema is usually sticky. And the moment both walls of the lung and the alveoli come together, what happens is it is very difficult to reopen them again, and you need a very high requirement of PEEP in case of ARDS. Subsequent slides will give you more of an understanding of the alveoli and why PEEP is needed, especially for ARDS. The next point over here is this ventilator, ICU ventilator, needs to have some amount of intelligence and some amount of sensing the reaction of the patient, and when a patient gives breathing effort, right? So when a patient gives breathing effort, this ventilator should be able to sense it, and also try to synchronize his breath with the breaths given by the ventilator. If you don't do that, you induce a lot of other kind of problems in the lung, majorly barotrauma and volutrauma that you're going to again. I'll explain this in one of the next slides. So we need to be very, very careful, and these ventilators are designed to be very sensitive to what patient is doing, and only then they can respond. And not only that, this whole ventilation circuit that goes into a lung needs to be completely leak proof. That's why you see those who need ventilation of this level, usually they need something known as an invasive ventilation, where they have an ET tube and they basically put a tube down your trachea, and then there's a balloon that blows up close to your lung, and what that ensures is there's whatever amount of gas exchange is happening. This gas exchange happens in a completely leakage free way. Leakage is the enemy of any ventilator, and it always throws off calculations by a long time, by really far, and it causes a lot of damage in the patient's lungs. So we need to be very careful, and there are a lot of standards to ensure that whatever circuits that are there and the internal circuits that are there, they are completely leak proof, so that the ventilator sensors work in a way that is reliable. And then last but not the least, the particular standard for critical care ventilators is ISO 8061-2-12, and this is a particular standard for the ventilator, and you need to follow this standard to get Europe EU marking, CE marking, and even FDA certification. Also, right now in the Indian market, if you look at ventilators are not a regulated product, and this standard right now is not needed to call out to make a ventilator. But it is in the works, and ventilators in India will soon become regulated. And if they put this standard as a minimum requirement, then it would make it would make ventilators a lot more complicated, and it would need a lot more safety precautions to ensure that whatever ventilation happens safely. So if you can see on the right top of the slide over here, you can look at lung capacity and tidal volume, inspiratory reserve volume, expiratory residual volume. So before we go on to our next slides, just to give you a little background, these are terms that you will see me or hear me use pretty regularly. So the total lung capacity is pretty straightforward, the total volume that a lung can carry during normal operation, right? And a part of that total lung capacity would be residual volume. That will be when the lung completely collapses and completely exhales. There will be some amount of volume of air still in the lungs. So that is what is called as residual volume. And then you have expiratory volume. So from the residual volume to the amount of volume that you need to inside to keep hold of PEEP, that you can see here, positive end expiratory pressure, is called the expiratory reserve volume. And on top of it, you have the inspiratory reserve volume, where you say the amount of buffer a ventilator keeps, knowing that your inspiratory reserve volume starts, buffer that a ventilator keeps. So basically, then we go on to the tidal volume, right? So this is something that you'll listen to a lot of ventilator manufacturers and designers always talk about. So tidal volume is the volume per breath that a ventilator can give to a patient. And this tidal volume necessarily is never the complete lung capacity, or it's not even the total lung capacity uh, minus the residual volume. This is always less than the reserve lung capacity, just to ensure and reduce the chances of volutrauma on the patient. And the tidal volume is always prescribed by a respiratory therapist or a pulmonologist, or whomsoever is the expert in that field. So let's get into one of the workings of the ventilator over here. You can see the ventilator predominantly has two inlet lines. One is air and another is oxygen, and both of them get filtered before they enter the ventilator, and both of them need to be 100% dry. So this is the major requirement for any ICU ventilator, and I think why it needs to be clean is very, understandable to anyone. But why they need to be dry is because any amount of humidity is going to hamper the working of any of the electronic sensors that you see along the line. And these sensors, mind you, need to be very, 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 very sensitive. So the air and oxygen enters through the filter, and they usually enter at a pressure of 60 psi, and they need to be dropped down to a pressure of around 50 to 60 centimeter of H2O. Now, from 60 psi to 50 to 60 centimeter of H2O is less than 1 psi. So it's a huge drop in pressure. And from industrial standpoint, from sensing standpoint, sensing anything less than 1 psi is very difficult. And getting very, very accurate sensors is very, very difficult in that range. So you can also see there would be an electronic pressure sensor before the regulation happens. So that basically connects to your microcontroller or your electronic circuits to ensure that if the inlet pressure drops below a certain amount of limit, it shuts down the ventilator, and ventilator throws up an alarm that, hey, there's not enough pressure in the line, and we cannot ventilate the patient with the amount of pressure you're giving. So once the pressure regulator brings it down to 50 to 60 centimeter of water, usually there's no regulator that can accurately bring down the pressure from 60 psi to 50 centimeter of H2O, sub 1 psi in one stage. So you usually have two pressure regulators working in tandem. So one of them brings it from 60 to 2 psi, and another one brings it from 2 to sub 1 psi. So usually the later regulator is more expensive, since those pressure ratings are not seen in the market, and you do not have enough demand, and also they're bigger and clunkier and more difficult to manufacture. Those regulators would be more expensive. After that, once you've regulated the pressure to a certain level, you need to get into flow control, where you basically control the amount of flow that is going into the patient. So in both of these cases, you need very high fidelity valves, and these valves also can control the flow in milliliters per second, in less than milliliters, like, or some of them will have very low resolutions, like of 0.5 ml per second or something like that. So when you have such high resolutions that are needed for these valves also can get incredibly expensive and impossible to manufacture in many setups. So they would need clean rooms, and they would need very high finishing to be to get that kind of a fidelity. After that, you get a flow sensor. A flow sensor here is nothing but uh, to all mechanical engineers out there, they would know it's just a venturi, and it measures differential pressure. It has got pressure sensors in two different places, and it detects minute change in pressure, and then based on Bernoulli's theorem, it can calculate the amount of flow that is happening through the ventilator. After that, this comes into something known as both oxygen and air comes into something known as a mixing block. This mixing block is where the mixing, of course, happens between air and oxygen. And there is some amount of challenges involved over here as well. So here, basically, the problem is the specific weight of ventilator of air and oxygen are very different, and the specific gravity of air and oxygen are very different, and they do not want to mix that easily. So although you put air and oxygen, it doesn't form a homogeneous mixture. It forms a heterogeneous mixture, and the danger of this being that there may be times when the first, I mean, if you give the patient 10 breaths, maybe 3 of them would be 50-60% oxygen, and remaining 7 of them would be like very low, less in oxygen. So both cases are not good. uh, I think sending less oxygen will ensure that the patient, I mean, he doesn't get enough oxygen and he gasps. And if you have more oxygen going to the patient, that also leads to a lot of medical complications, and they end up, burning your trachea or the bronchi, and they cause excess amount of oxygen also causes a lot of damage to the human body. So once you have ensured that in the mixing block that both air and oxygen are mixed homogeneously, you send it through a pressure oxygen cell, and the oxygen cell is also known as an FiO2 cell. And the FiO2 cell essentially measures the percentage of oxygen that is there, and ensures that the flow control happens in such a way that the amount of oxygen the that the doctor suggests is the amount of oxygen that's going to the patient. So this is one, and then the final piece is the emergency pressure relief. So this is a mechanically set valve, which has no, you cannot set that valve. This is preset by the manufacturer and left. So this is there always to ensure that if there's any problem in the whole ventilator, and if any of the electronics fail, you should never have more pressure getting into the patient lung, which would lead to a lot of lung damage and even death. So this pressure relief always ensures that if there's a software has a bug or the electronics have malfunctioned, any of the valves have malfunctioned, that whatever it basically releases all the pressure and gives only what is acceptable to the patient. And no surgeon or no doctor can even get access to this valve, or it's neither settable by them. So from here it goes to the patient, and when the patient inhales and then he exhales out these gases. So when the gases get exhaled, you come to the orange side. So it comes to the exhalation valve, and from the exhalation valve, this exhalation valve is majorly uh, responsible for ensuring PEEP, as what I had told in the previous slide. So this exhalation valve allows how much ever pressure above the set PEEP to go out and the gas to go out. But as soon as the PEEP is reached by the patient, the pressure that is supposed to be there within the lungs, this exhalation valve basically stops the breath and doesn't let the patient exhale fully. And the flow sensor here basically measures the amount of air that goes out, and the exhalation pressure sensor also measures the pressure at which the patient is breathing out. And based on that, you can see there's small amount of air that is taken from the input airline, and this is controlled with the right valves to ensure that whatever PEEP is set by the doctor is executed on the patient. So you would have a diaphragm, and you would just have a diaphragm, and one side of it you have patient pressure, and another side of it you have the pressure given and set by the doctor. So as soon as the lung can overcome the pressure set by the doctor, this valve basically just leaks out, and then also starts blocking once the pressure set by the doctor and the pressure in the patient lungs are same. You basically stop the breath. So after this, we get on to the breathing modes here. There we go. So there are predominantly 4 modes here. So you can say there is volume assist and control mode. So in volume assist mode, you have a preset tidal volume, and only that is what is an input taken from the doctor, and other pressure curves and pressures are not controlled by the doctor. The ventilator sets the pressure to ensure that at what respiratory rate, if you can see, that's what I mean by respiratory rate is the number of breaths per minute, and what breath per minute is maintained to give that amount of volume to the lungs of the patient, and also complete the breath. So it basically only controls the volume that goes into the patient, and does not, it just monitors the pressure and checks for safety against excessive pressure, but it does not control the pressure at all. The second mode here is called the pressure assist control mode. So this is basically inverse of the volume assist control mode. So what happens here is you basically control the pressure, and only pressure is controlled here and volumes are not controlled here. So as soon as the lung reaches some amount of pressure, your the ventilator switches to an exhalation mode and lets the patient exhale the air. So the next mode that we come across over here is called pressure support mode, and pressure support mode is largely also done by ICU ventilators, and also there are machines in the market called BiPAP or CPAP that can do this kind of ventilation. So this basically just supports whatever breath you're doing. That it basically only gives you some pressure that when a patient can breathe. So this basically just eases the method of breathing, that the patient doesn't need to do too much effort to have a breath. Last but not the least, I think synchronized intermittent mandatory ventilation along with pressure support. So that this is usually called SIMV along with PS in the medical fraternity. And why this mode is very important is this is the mode where the ICU ventilator basically synchronizes with the breath of the patient, and then it it lets the patient breathe and gives mandatory breaths to the patient as decided by the doctor. So a doctor can basically say, okay, that I would give 5 mandatory breaths in a minute through the ventilator, and the other breaths will be taken by the patient itself. And the patient would be taking, and this mode over here will be basically monitoring all the breathing characteristics of the patient and synchronize the breath as given by the ventilator to the patient. So in all of these ventilation modes, let's get into each of these in a little bit of detail over here in the next slides. So if you can see, the first mode over here is controlled ventilation, and this controlled ventilation can be both pressure control and volume control, like I'd said in the last slide. And this is something that you would see very commonly in an anesthesia ventilator as well. So you would see that in volume control mode, you would have a preset flow, and the flow would keep increasing inside a ventilator till it reaches some amount of peak, and then the flow direction basically reverses. That flow starts dropping here, and then the flow comes back to normal when the breath is completed. And similarly, if you look at the pressure here, if you see volume control ventilation, you can see that both the pressure curves are different. So the pressure here is not monitored at all. You can see the first pressure would reach some amount beyond which the safety would cut it off. And the next breath, the same pressure is not reached. But in volume control mode, you can see that the volumes are always maintained, and the tidal volume given to the patient is always the same across 2 to 3 breaths. And once one tidal volume is met, it allows the patient to exhale out, and again uh, the tidal volume goes up, and then again it allows the patient to exhale out. In pressure control ventilation as well, you can see the same thing happens, but here you can see your pressure is always constant, whatever the doctor has set, but the volume keeps changing. The tidal volume that goes into the patient keeps changing. And before I go on to the next slide, I would just want to say that these slides are pretty much into the uh, medical domain and electronic domain, and I'm not an expert in that domain, so I have basically referred to Dr. Lokesh Tiwari here, whom you can see on LinkedIn, and taken these slides from one of his presentations. And then we can get on to assist control ventilation. So the problem with the control ventilation, before I go on to the assist, is that it is only time driven. You can see that here the breath that are given, that is just given to a particular time duration that is set by the doctors with the number of breath per minute. So if the doctor said set it to like 20 breaths per minute, the ventilator will give the patient 20 breaths per minute. So this control ventilation is always used when the patient is completely sedated and or in coma and cannot breathe at all. However, when you come to the next stage of ventilation, it is called assist control ventilation. Some anesthesia ventilators have it, but but it is this feature is mostly there for ICU ventilators. And you can see here in assist control ventilation, uh, here the ventilator keeps monitoring the breathing mechanics of the lung, and once it keeps monitoring the breathing and realizes that when a patient needs a breath, and only gives a breath when the patient needs it. So the doctor cannot, set number of breath per minute or something like that. Here the patient will only be, the ventilator will only, respond to the effort of a patient. So if you can see here on the assist control ventilation pressure, you can see PT triggered. So you basically have a trigger, you have a breath trigger. So the moment the sensor of the lungs that is sensing the pressure in the lungs detect that there's a drop in lung pressure beyond a certain limit, which is maybe 25% of the PEEP, it basically decides that okay, this is not the amount of breath that a patient needs to have, and it starts giving a breath to the patient as against a time triggered one, which basically doesn't take that any input from the lungs. So here also I would say that this is not used regularly on a patient who is fully conscious. This is used on a patient who is basically sedated or coma or in coma and or is trying to get out of coma. So this is used in this mode is used in those cases more often than not. After that, let's come on to pressure support ventilation. So when you come to pressure support ventilation, it is pretty evident that this, if you can see the name itself says, this is just support. So this ensures that your patient is just breathing normally, and this just aids it. So if you can see here on this pressure support ventilation slide, you can see that whenever the patient exhales and then inhales, this pressure support ventilation just enhances the amount of inhalation that a patient does. And then the patient doesn't breathe, even the pressure support doesn't do any work, and then patient exhales again. And then when again he inhales, he inhales a lot more than what he would do normally with his own effort. So this is used when a patient is not having enough energy, or his lung is not functioning enough to take in the amount of breath that is needed for him to complete breathing cycle and ensure that his body is oxygenated enough. And although he can take breaths, but the breath is taking a lot of effort and he's not able to oxygenate his body enough. So that is where this pressure support ventilation is used, and they are typically they are even given to homes, these kind of machines. They are called CPAPs and BiPAPs, as I told you earlier. If you can see the first image that I have over here. I don't know if you can see it properly, but if you can see here, during the pressure breaths given by the ventilator, you can see small breaths being taken by the patients over here. So here, if you can see, the patient is trying to take a breath, but the ventilator is not helping. And you can see a condition here where the ventilator has forced him to give a breath, whereas the patient was trying to take a breath as well. So these are conditions where you basically end up damaging a patient's lungs, because either he's trying to breathe differently, that leads to barotrauma, and also it leads to a lot of distress in the muscles around the lungs of the patient, and because the patient is forced to breathe despite all efforts of the muscles around his lungs. So this is where a need for synchronous ventilation comes in, that when a patient is trying to breathe, you only basically give a breath then, and you do not give a breath otherwise. That is what synchronous ventilation means. And coming to the next slide, you have something called as SIMV, so synchronous intermediate mandatory ventilation. So here you can see where a doctor can do a trade-off, right, with pressure support. So when a when a patient is breathing, you just aid his breath with pressure support. But during one of his breaths, maybe whatever the patient says, doctor says, you need 5 breaths a minute or 8 breaths a minute. The ventilator synchronizes with the breath of the patient and gives a major breath with the help of the ventilator. And then the ventilator keeps quiet and keeps monitoring the breath of the patient again for the next couple of breaths. And again, it goes only when a patient is trying to breathe. So this mode doesn't come into a picture otherwise. This mode is also used with patients who have asthma and diseases like that, where they have a lot of effort to breathe. They have to give a lot of effort to breathe, and they keep breathing. And this ventilation just helps them with the effort. So, uh, coming to the trauma caused by the ventilators on the lungs. So you have, first of all, ARDS, right? So if you go back, this is the same condition of the lungs that is caused by even COVID, and even a ventilator can introduce ARDS as well. The next one is volutrauma. If you can, barotrauma. So if you can see the right two images, the top and bottom images on the right, you can see that if the alveoli over here is closed completely, and you're just giving him too much pressure, giving it too much pressure, you would see that the bronchi of the lungs would start breaking in different. It would bulge and just pop out, or it would just shear out in this case. And this amount of damage on the bronchi would also would ensure that there would be more edema in the lung, because the body will try to repair this by giving it some blood and energy to heal quickly. So that is what happens. And on the left side over here, you can see how an alveoli works basically. So you can see air comes in, and the alveoli is the sac around here. And then you can see impure blood coming in. And as soon as the air comes in, there is a osmosis happening here, and the air basically goes, sorry, not osmosis, diffusion happening here. So air which has higher concentration of oxygen, the oxygen gets into your uh, blood cells, impure blood cells, and they get oxygenated, and the impure blood cells let out CO2, which get into the alveoli, and it's sent out to the uh, during exhalation. So it's in this alveoli where basically oxygen exchange happens. And whenever you're maintaining, you're giving mechanical ventilation, it is of primal importance that this alveoli is always, is not damaged, because these cell walls are very thin, and these walls that causes diffusion are very, very thin there, you can see. And because of that, if you give excessive pressure or excessive volume, they would rupture within no time. So coming to volutrauma over here, volutrauma is something that happens over here, if you can see, right? So if you give this alveoli too much of volume, so you basically, it's like a balloon, and you give it too much volume, it expands, it expands, it expands. After some time, it just pops open, and this pretty much affects the membrane of the alveoli, and also it gives a lot of stress to the lungs. And the lungs have many alveoli, and I think a few of them get, I mean, if not taken care, all of them can get damaged with volutrauma. And also there's atelectrauma, which is if you let the alveoli wall stick, like in this case, and then you force it open multiple times, even then this wall gets damaged. And that is where the requirement of PEEP comes into the picture that I discussed earlier. And to ensure that doesn't happen, you need to have some amount of PEEP, and in ARDS the amount of PEEP is usually higher. And you ensure that your alveoli walls do not collapse onto themselves completely, like what is shown in this image, and they always have some amount of air inside them. And lastly, that the ventilator can also cause pneumonia in patients, and the primary response the primary thing that happens over here is because the internal circuits of the ventilator are out of, you know, patient or sterilization requirements. You put filter in front of them to ensure that that circuit doesn't get infected, or germs don't live there. But however, no matter how many filters you put, there are something that escapes, and because of this, it is very difficult to clean the in inlet airway pressure. But however, the exhalation ports that deal with more patient output are can be sterilized separately. They're detachable, and they can be sterilized separately. But however, in ventilators, you have to be very, very careful just to avoid cross infection. I think that's it from my side. If anyone has any questions, you can ask.
Before I guess we compile any questions from people, uh, I, okay. To me, this is like space tech, right? Like
Right.
there's literally too many complexities involved, too many sensors, and this is a complex setup that's out there. And as you said, that things can fail in any place, and you have the safety valve at the end, which just ensures in
Yeah.
case of
Yeah.
failure, it just stops. So like I see it's complex and how even to make one. But how long does it actually take to make one of these, and how much of money is usually does it cost?
So, if you're looking at development of a ventilator, it'll easily go into years, right? If you're trying to start from scratch, if you're reverse engineering something, or you have the design already, it will take you less amount of time to make it, but the cost involved will be very high. You will have to source valves, and you will have to make valves and manifolds, and the amount of you will need to have proper industry machines and proper setup, and also have good source of these valves, because these valves are traditionally very difficult to make, and they because primarily because of most of these valves are made by hand, right? So the most critical valves here are basically finished by hand and then sent out. So even the companies that are manufacturing them have a manufacturing limit to the amount of valves they can make, and then when they send it out to the companies, and then they need to assemble it properly in a manifold and have a very good clean room setup where these valves get manufactured, and the setup cost and the manufacturing cost of these will be very high. It would go into crores even, if you're trying to develop this.
Okay. Uh, what do you think about this whole open source ventilators that people are trying to develop with using
Right. So
simple
most of
alternative sensors?
yeah. So most of these open source ventilators, if I come back here, they would work on any one of these control ventilation kind of setup, right? And they can work very well if the patient is sedated completely or is in coma, and you have to keep him alive, and there is no lung function at all, and you just keep him alive. So you have either lung volume control or you have pressure control. So most of these low cost ventilators would essentially stop in this mode over here. And if you want to go beyond anything beyond this mode, like maybe an SIMV mode or a assist mode, you would need, like, we are talking about pressure sensors over here that typically sense around 1 centimeter of H2O kind of pressure. And in engineering, we know, right, that if you're trying to measure something, it needs to be 1/10. Its least count needs to be around 1/10 to 1/5 of what you're measuring. Otherwise, what will happen is, if your least count is more than 1 centimeter of water, you would never get accurate and reliable values, because your error is more than what you're trying to measure. So you would never get good values. So you need to get those particular sensors with around zero point 0.1 to zero point 0.2 centimeter of water accuracy to be able to measure these kind of values. And getting those sensors would be would be tremendously cost expensive and also time consuming, most importantly.
Okay, so some of these ventilators that people are trying to build will only be helpful in specific scenarios, but COVID in itself may not be, not so much.
No, in I would just say it would not help in ARDS. In
Okay,
fact, if not careful, these ventilators will cause ARDS.
essentially damage to the lung.
Yes.
Yeah, interesting. I guess there are not many questions out there. Maybe we'll redirect people to the comments. If anybody has questions post the event, you can actually
Mhm.
post in the comment section of the page and we will redirect them to Krishanu.
Okay.
I guess we'll end it here. It was a really interesting talk. I guess I'm not sure how many people in India are actually developing this, but I do come across people trying to post images saying we're trying to do it. Like,
Right. So I see a lot of efforts around the world, even in India. I hear a lot of people even contacting me. But I just want to say this, right? So if you're planning to make a ventilator, I will not discourage you. It's, the more manufacturers of ventilator, the better it is for humanity. But you need to be into it, in it for the long. It's not something that you can turn around in a couple of months.
yeah, so I mean, we have this startup space in Telangana called T Hub. So there's
Mhm.
some, it's kind of a maker space. I guess they have this hardware division called T Works.
Mhm.
So there are a bunch of folks who were developing one and they developed a prototype. I guess they're testing it with the doctors, but so yeah, I guess how do you test these? I mean,
Right.
you tell about the manufacturers, but
So when you test one of these ventilators, the first thing you need to do is you need to buy a lung simulator. So any of the high end, like any of the ventilator manufacturers, have a lung simulator. And if I can get back to the slide, right? There's this ISO standard over here, right? So the ISO standard calls for you to test it on that simulator. And when you buy that simulator and test all your modes on that lung simulator and ensure that all lung compliances and all lung conditions are the ventilator is behaving to is proper and acceptable, only then you can sell this ventilator in the market, right? So without a lung simulator, uh, even if you say a doctor is testing this untested ventilator on a patient, it is basically unethical. You should not be doing it.
I mean, do we usually have lung simulators in like educational hospitals
I
or
don't think so, because it's a very expensive piece of equipment. Most people think test lungs are lung simulators, but it's not. A lung simulator is a machine that can easily cost upwards of 10 lakh rupees. And then it's very difficult to maintain because you have to send it out every year to calibrate to the US or to whomsoever is the manufacturer of the simulator. And then it goes to them and then they calibrate it and then they send it back every year, year on year. And it's very expensive to keep and it's very expensive to maintain as well. So that's how you got to test a ventilator. And it's very difficult. Like designing a ventilator can take you between a couple of years or 3 years, and then when you figure out the testing, that will take another year or so.
okay, quite time. So I have one question from the audience. He was like, there are these new ventilator splitters, like mask
Oh
splitters,
yeah, yes, yes.
where they're providing one ventilator for multiple patients.
Hmm.
How does that work? So you have
So
same synchronized breathing.
So long and short of it is, in most cases it does not work, right? So let me let me be very clear here. But however, there are few cases under which they work. So if I can come down here, if you go to volume control and pressure control, in these cases also they will work, provided one of these splitters have some kind of a valve which controls the amount of volume that gets into different. See, basically when you put two different patients, you've got two different lung compliances. And if you're trying to do synchronized intermittent breath on them, it is impossible, because a ventilator would not know which lung is behaving in which way and which lung is trying to breathe. So it will become very difficult to do SIMV on them. Pressure support is possible, is one of few things that's possible. Pressure control is possible, but pressure assist is not. And volume assist and control is also out of the picture. But pressure assist and pressure control is possible with the condition that both of these lungs have the same pressure and both of and compliance, and then whatever the splitter is can give two different volumes to the size of the lungs. Otherwise, you will need to look for lungs that will need same tidal volumes. And when it needs the same tidal volumes, if you have a like if you have 10-15 patients, you will not even get a single patient who has who needs the same amount of pressure and who needs the same amount of tidal volume. It's statistically very low, so they would not help you in any way. So these are very few conditions where you can use these splitters.
Okay, so it will help provided you have these kind of ventilators, and where you're also you are controlling the flows.
Yeah,
Which brings me to the question, like how trained should a medical professional be to actually operate this system?
right. So respiratory therapy is a field of paramedical in itself. You need a BSc or an MSc to do it. And even the pulmonologist and all, they have to do your MBBS and they have to do your complete, masters and other things to be trained enough to understand enough to be able to handle a ventilator. So even nowadays in hospitals, right, the people, those who are nurses and all, do not set a ventilator. It's these doctors, those who do, they come and set it, and then these ventilators. I need to bring up one more point over here. Most of these ventilator handles patients for weeks and months, even years. We've always heard of patients who are there in the ICU for a year or 2 years or 3 years in coma, and then the family cannot pay for the ventilator anymore and stuff like that. But this ventilator is supposed to be doing that. So can you imagine the amount of reliability that a machine needs to have to ensure that in a year you can imagine this gives 20 breath in 1 minute. In 1.5 years, how many breaths this machine gives? And all these breaths should be reliable all the time. Even if one breath goes wrong, it kills the patient. Right? So that much amount of reliability needs to be built into these ventilators, and that's what's very important for us over here.
It brings out that most of this is like a very complex problem, both in terms from a healthcare perspective and even from a tech perspective, whether it's
Yes.
mechanical engineering perspective. Rather, I
Yes.
don't want to call it tech per se, but
Yeah. Yeah.
in
Yeah.
terms of both mechanical and electrical. Uh,
Right. So I would want to bring one more thing into consideration over here. Making low cost ventilators is not something new, right? If people are thinking right now, oh, COVID has come and we have to make low cost ventilators. No, it's not something that is new. Engineers have been trying for tens of years to try to make something low cost and something more accessible, but it's not possible. Many of the African countries, few of them don't even have a single ventilator, and they have dealt with pandemics like Ebola. And like for example, Nigeria has one ventilator, right? And it's people are trying to make it for a long time now, and this is where you hit a roadblock where you say, oh, okay, this is what the laws of physics allows me to do, and this is what laws of physics doesn't allow you to do. It's you cannot go more than the speed of light, right? I mean, that's what it is. It's a physical boundary that you are fighting against over here.
okay, on that note, thank you so much, Krishanu, for explaining these basics of how ventilators work. I hope people understand what they are trying to do when they are attempting to build some of these, and hope more people also learn about this, and more medical doctors are also trained on these. And we'll end it here. If you have any more questions, please comment on our page, and we will ensure that they reach Krishanu, and we'll see we can get it replied for you.
Okay, thank you. Thank you.